Hi, everybody. My name's Lawrence Freedman. I'm Emeritus Professor of War Studies here at King's, and I'm delighted to be able to chair a session this afternoon on entitled Covid-19, Mapping Intersections Between Security and Health. It's part of a wider conference organised by the School of Security Studies at King's, entitled Covid-19 and Other Tales of the Unexpected, Understanding the Security Implications of Global Shocks Past and Present. We've got 5 speakers, so there's a lot to get through. So I'm not going to spend a lot of time on introductions, just to note first that this is being live streamed on YouTube. Each presentation will last for about 10 minutes. If you have questions, you can pose them on the panel to the panel at any point during the session. We'll probably take them largely after everybody's spoken, but do so through the Q&A channel at the bottom of your Zoom screen. We'll group them and we'll see what we can do with them after the presentation. Please include your name and affiliation with your questions. If you want to comment on Twitter, it's #GlobalShocks. And with that very brief housekeeping introduction, I'm going to move straight to the first presentation, which is by Professor Richard Sullivan, who's Professor of Cancer and Global Health at King's and co-director of the Conflict and Health Research Group. So over to you, Richard.
Sir Lawrence, ladies and gentlemen, thank you very much indeed. I'm delighted to be here this afternoon to share a few thoughts with you about the current pandemic in the civil and security context. Let me begin by saying that really this pandemic has exposed all the strengths and weaknesses in the global systems, be they economic, social, health, or security. Yesterday's webinar that we had with the security studies, we had Professor Sir David Omond remark, should we have been so surprised about the Covid-19 pandemic? To which I think the short answer must be no. Epidemics and pandemics are really a normative aspect of the biosphere, from the plague of Athens all the way through the 1980 flu pandemic to today's extraordinary range that I've illustrated here in this first slide. And indeed, this particular novel coronavirus is the 7th coronavirus to enter the human biosphere. But for both the civilian and security sectors, I think it's fair to say that this is a very kinetic and complex ecosystem, a huge variety of biothreats that are known, and of course, a load of known unknowns, what we consider to be the disease X's, the ones we don't know about that have not come through yet. So in reflecting on the civil security context of this pandemic, I think it's important to understand the history of preparedness. And here I have a few thoughts on this. I think the first thing to say is, by and large, the security and civil sectors have ploughed their own tracks, really for a variety of reasons over the last 20 years. In the sense the civilian side has been concerned with human security, whereas the security side has been very much focused on bioterrorism. We have very different ideological approaches as well. On the civilian side, humanitarianism compared to classical security. And also, we've seen situations where knowledge has not easily transferred between these two sectors. For example, in unilateral endeavours, the Department of Defence had this extraordinary biosurveillance of over 260 sites in 56 countries by 2006. Yet the movement of this sort of knowledge and understanding between civilian and security sectors has not been easy at the best of times. The other thing I think in reflecting on where we are with preparedness is the decline really of biointelligence. I think it's fair to reflect that amongst the NATO security sector, biointelligence has taken something of a hammering post-Butler report in 2004. And indeed, post 9/11, it really moved right to the back of the bus. Indeed, one can say when we think about CBRN, the B, the biological element, really has been in lower case since then. However, to a certain extent, I think the 2014 and 16 West African Ebola outbreak was somewhat of a renaissance moment for the security sector involvement in high-threat infectious diseases, and indeed for the civil-military interface as a whole. And we had some very important reflections and lessons learned, very well articulated by people like the Surgeon General then, Martin Bricknell, now Professor with us at King's College London, and by the Department of Defence in a very important and interesting insight in their analysis of Operation United Assistance. Yet if you look, very little of this information actually transferred across to the civilian sector. So when we look at preparedness, what we see is a lot of ambiguity and confusion about what defines health security. We've seen a long history of civilian security sector running on parallel tracks, and lessons maybe haven't been learned, they've been unlearned or not shared. And indeed, there have been huge changes in the balance of power, decline in the security sector post-Butler report. That's not true of all countries. A very strong weakness in the global public health system. Outside Europe and North America, for example, in terms of surveillance, just basic vital statistics mortality, less than 25% of countries have this. And a very strong focus and rise in civilian science around epidemiology and modeling. So what about the responses? Well, it's been interesting because when we look at this, since the 30th of January 2020, when WHO declared COVID-19 as a public health emergency of international concern, people have actually been looking to see how well individual countries have responded. And rather worrying, to date, when we look at the Civilian Developed Global Health Index, it's only really been predictive in a negative sense. In other words, the countries that were supposed to do well have actually performed worse, which suggests that the index wasn't fit for purpose in the first place, and there are some serious deficits underlying most of our responses. The range of civil military responses has been extraordinarily broad. We've seen very highly securitized responses from places like China and South Korea through to almost purely civilian. We've seen a very large and diverse range of non-state armed group responses. And we've also seen extensive cross-border assistance, for instance, the Chinese security sector helping Vietnam, the Pakistan forces helping in Afghanistan. And I've always thought this is slightly amusing, this small picture in the left-hand corner is indeed even the Taliban have got in on the act. And that's a testing station in Taliban-held territory with a PK machine gun, I think that is, on the desk. It does make you wonder what would happen if you were to test positive. So moving ahead, what we can really look at when we're doing a sort of meta-analysis is the security-led responses have tended to be very ecosystem unique. And there's a lot of scholarship that probably needs to be done yet to understand exactly what the role of security sectors played in individual countries. When we've looked at the purely civilian-led responses, I think there have been few good examples. A lot of the pandemic response has exposed serious deficits, anything from collection plans, information analysis, for example, the cause of death, private consultancy firms misusing modeling, etc. And indeed, there have been very few people and organizations that have really what I consider to be straddling the civil-military interface. And here I just want to point out two individuals and papers well worth reading here, Jim Wilson and Pat Walsh. But these are the exception, not the rule, when it comes to scholarship around the interface between the civil and the security levels. Looking forward to the future now and really in sort of wrapping things up, we've already seen the start of a lot of work now trying to unpick what has happened with the responses and the relative roles. And I think it's fair to say that this idea that we're going to actually move forward has to be sort of informed by very cold calculations in the cold light of day. And this banner here says no trust, no panic, no trust. No panic, trust science. Now, this is absolutely correct. One has to trust science, but science is only part of the future situation in terms of actually sorting things out. Scientism is not the only objective means by which societies should determine their normative values in pandemics. And in terms of situational awareness or strategic notice, we need a much wider picture. I think in terms of where we're going for the questions that remain unanswered that have to be addressed, three things come to mind. First is global health security is certainly divided politically and fragmented analytically. And this is something I think a great deal of attention is going to have to be paid for going forward. I think there are a lot of questions around the relationship between biosecurity and biointelligence, particularly within the existing public health approaches to preparedness and response. And again, I commend to you sort of 3 publications here, a very nice collection led by Mike Goodman, Philippa Lensos, and Jim Wilson that appeared recently in Intelligence and National Security collection. And then more in-depth pieces of work, Gemma Bauscher writing on medical intelligence, you're going to hear from her in a minute, and some very nice work from Rose Bernard looking at the role of human intelligence within pandemic preparedness. But at a much higher level, I think we also have to develop global cooperation between countries and between the security and civilian sectors. And again, the pandemic has really exposed a lot of deficits with this global cooperation. More broadly, what will be the long-term impacts on peacekeeping and security operations? How do we address new bio-cyber conflicts? And for what are the limits of participatory signal intelligence, for example? What will it mean for the political economy of health, the stability and security? And indeed, how are we going to rebuild security sector biointelligence? My final slide really comes back to this point of needing a radical rethink around preparedness and response. COVID-19 is not as bad as Ebola, but it's fair to say that the next pandemic might be, and this particular pandemic has to be a wake-up call for both civilian and security sectors in rethinking preparedness and response. Thank you very much indeed, Sir Lawrence.
I can't talk.
Good afternoon, everyone. I guess we'll just go straight into my presentation. I'm going to try to share my screen with you. And there we go. So this afternoon, I'm going to be speaking about investigating COVID-19 origin narratives. And I'm going to go through some of the key things that we know and that we don't know, as well as sketch out what I think needs to happen next. And I'll end with a very brief reflection of my experience of the research process over the last few weeks. So there is much uncertainty about how the pandemic started. And to confuse the situation, there's also been a great deal of misinformation, as well as active disinformation, suggesting that the virus was deliberately manufactured as a biological weapon. While there are some concerns about China's militarization of biology, this aspect does not form part of the origin story. And I think it's important to put that out there right at the front. What we currently have in terms of genetic evidence suggests that the pandemic resulted from a natural spillover event, with the virus jumping from bats to people, possibly via an intermediate animal species. What there is less evidence about is where that spillover event actually took place. The prevailing theory is that the spillover event happened at a market, the Wuhan seafood market. These kinds of wet markets where animals are kept in cages in close proximity to each other and are slaughtered, cut up and sold on the spot provide ideal conditions for viruses to jump from one species to another. And it is a fairly likely origins theory. Some of the early cases had connections to the market and support the theory too, but not all. So 3 out of the 4 first cases, including the index case, that's the very first case, did not have links to the market. Another plausible possibility is that the pandemic could be the result of safety lapses in the course of basic scientific research. And there are 2 institutes in Wuhan that are working on coronaviruses. The Wuhan Center for Disease Control, which is located just a few hundred meters from the wet market, and the Wuhan Institute of Virology, which houses the world's largest collection of coronaviruses. Now, there are hundreds of different strains of coronaviruses, and these are generally harmless, at most causing a common cold in humans. So coronaviruses are generally classified as relatively low risk to work with. They're to be studied at biosafety. It has been judged that they can be studied at biosafety level 2 in laboratories. Problems arise when new dangerous coronaviruses unexpectedly appear, like the ones causing SARS, MERS, or indeed COVID-19. And this is because biosafety level 2 containment only provides minimal protection for workers and the environment. Now, while coronaviruses were studied at biosafety level 2 at the Wuhan CDC, they were also studied at higher containment levels at the Wuhan Institute of Virology. This is because one of the things scientists were doing at that institute was infecting lab animals with coronaviruses. They were also engineering chimeric viruses or hybrid viruses with genetic mixtures of 2 or more different viruses. These kinds of chimeric viruses can sometimes result in new viruses that are even more dangerous than the parent viruses. And this is, for example, what happened when researchers from the Wuhan Institute of Virology combined a coronavirus circulating in Chinese horseshoe bats with the SARS virus, as they report in this 2015 article in the prestigious journal Nature Medicine. So in terms of the origins of COVID-19, could researchers working with coronaviruses at these institutes unknowingly have become infected and, without developing any symptoms, unwittingly have gone on to infect other people? Or could improperly incinerated waste or animal carcasses from research perhaps have been the spillover trigger? Now, in addition to lab work, researchers from both institutes also carry out extensive field work to obtain viruses from bats. This is also highly risky work, carrying clear risks of infection when scientists collect viruses from bats. Could the spillover event have happened through direct contact with bats, perhaps? Questioning whether there have been safety lapses in the course of basic scientific research is justified. Not only do accidents happen all the time in labs around the world, there have been reports of poor biosafety standards in China generally, as well as documented concerns about biosafety at both the Wuhan Institute of Virology and the Wuhan CDC. Adding fuel to these reports, there are indications that Beijing is deliberately diverting attention from scientific research as a possible source of the pandemic. Beijing placed severe restrictions on the publication of pandemic origins research. So now academic papers on the topic are subject to extra vetting and approval by central government officials before they're allowed to be published. We're also seeing documents actively being taken down from institute websites, including the Wuhan CDC and the Wuhan Institute of Virology. It's also common knowledge that Beijing has made significant attempts to control the pandemic origins narrative since the very beginning of the crisis, that Chinese investigative journalists take great risks in reporting on the outbreak, and that doctors who early on in the outbreak shared information about what they were seeing were subsequently summoned by the authorities. So what happens next? Well, at the World Health Assembly meeting in mid-May, the international community decided an international investigation should be conducted, and this is good. But few specifics have been offered on the sort of investigation that is needed. If it is to be a genuine effort to query origins, I argue that answers cannot solely be drawn from virology, infectious disease genomics, genome science, and epidemiology. Investigating the range of possible spillover sites from the wet market to an accidental lab or fieldwork infection, to an unnoticed lab leak, or to something else entirely requires a forensic investigation. a forensic investigation that establishes a likely chain of events, enabling the investigation to shift from a could have been to a probably was. And this needs to happen sooner rather than later, before all traces are blurred. Now, I've written more about the possibility of a lab origin and a forensic investigation in a pair of articles published in the Bulletin of Atomic Scientists over the last few weeks. The first of these covers the possibility of the pandemic resulting from safety lapses in the course of basic scientific research. And the second looks in more detail at what forensic investigation would actually involve. Finally, some brief reflections. A credible investigation is needed for a number of reasons. It's needed to better understand the animal to human transmission aspects of coronaviruses. It's needed to prevent future outbreaks, as well as to strengthen surveillance and preparedness. It's also important as a way of combating misinformation and disinformation campaigns that confound responses. For me, the investigation is also important because it feeds into bigger societal debates that we still need to have about the sorts of risks we're willing to take in the name of research. Does the majority of stakeholders feel that lab manipulations of potentially pandemic pathogens is justified? Do the benefits of virus hunting outweigh the risks? Can we even do adequate risk-benefit assessments when both risks and benefits are uncertain? And finally, on a more personal note, as critical researchers, we are often counter-current. And sometimes we end up in uncomfortable spaces. In this case, my work ended up supporting the same narrative that the Trump administration was pushing, albeit for very different reasons. A research or lab-related origin theory also goes against the heavily vested interests of scientists, funders, and publishers supporting potentially pandemic virus research, including some very established PIs, the NIH and the WHO. So just to table an end on that idea, that critical inquiry can sometimes come at a cost. Thank you.
Hi, thank you very much, Philippa. I think critical inquiry is what we do, so we have to go wherever it takes us. But I also was a critic of WHO and also found associations at times uncomfortable, but there you are. So we're now going to go to Professor Brooke Rogers, who's Professor of Behavioural Science and Security here at Department of War Studies, and is speaking as that and not in any other capacity. She's going to be talking about learning from the past, looking to the future. Brooke.
Thank you, Laurie. I will just share my screen. Okay, there we go. So good afternoon, everyone. It's a pleasure to join you and to engage with my colleagues, some of whom I haven't seen in a while, in pushing forward in this area. So I'm going to focus in on my area, which is behavioral science, and look at the role of behavioral science in evidence-based policy and practice. In doing so, I'm going to look at the current research and development landscape, provide some examples of evidence-based policy and practice in which we can see very clear links through the theory, in terms of the theory's impact on practice or on measures used within government. I'm also going to look at some of the ways, some of the broader ways in which behavioral science has influenced practice within the UK and beyond. And finally, I'll just give a little bit of general, we'll do some general reflections and possibly provide some general advice that could be relevant to other areas in terms of my experience in this world. So I'll just begin by saying that I engage with several policymaking organizations and bodies and practitioners and a variety of local, national, and international advisory roles. These can include Public Health England. Sometimes it's working with practitioners on research sandpits, where we try to bring different groups of researchers and research skills together to solve shared problems. Other organizations such as the Communities Prepared National Group, Counterterror Strategic Summits, et cetera, et cetera. So I've done a lot of engagement in my time. A lot of this has been through informal links that have been built through conferencing, through practitioners who have attended my MA courses, practitioners who have become PhD students. And also, I think it really all started when my colleagues and I started including practitioners in our research projects. So we started by exploring public reactions or responses to extreme events, and in doing so, realized that we also needed to understand the way in which practitioners, let's say from the emergency services or industry and policymakers, understood the risks and threats, understood public behavior, and the activities or the plans that they put in place in order to help manage that public behavior. Other engagements are formal or more formalized through research funding, through advisory roles on scientific advisory committees or expert groups, through assurance roles and challenge roles, although I think that those are quite often needed across all of the groups. So you're there in those groups in order to issue challenge, in order to bring evidence to bear on the conversations. But also, I think if you see things that are going well, to bring the evidence into that and to say, yes, you're actually following what the academic literature would say or the academic evidence would say in those cases. I've worked across emergency preparedness exercise, drafted reports, including planning assumptions, and engaged in different working groups. So it's quite a busy life if you want to be an academic who engages in this area, but the research feeds directly into policy and practice, and the policies and practice also feed into the research. I'm going to start with one of the most recent reviews of our science capability in the UK, which was called Realizing Our Ambition Through Science, undertaken by the Government Office for Science. I think it's important to note that the last major review of government science took place in 1993 and 2007, and then this came along in 2019. It's important to recognize the nature of science and the context in which government operates has changed beyond recognition in the decades since the reports were published. For example, the internet, data revolutions, additional complexity in policy making, society and the economy. All of these are changing society and the economy significantly. And then those changes also issue structural challenges to the way in which we think about science, undertake scientific research, and even the way in which science is funded in the UK and beyond. This report contains a number of interesting recommendations for enhancing the use of science to promote government effectiveness and better policy making. And if you're really keen, if you go over to page 29, they do address the publication of departmental areas of research interests. 15 of those were published by November. And these illustrate areas where there is a need for more capability in future areas of policy that cut across different departments. Some of the ones that were at the top of the list, and I've emboldened behavioral science, data science and health issues, demographic issues, and the environment. So those are the areas where they're really, really keen on finding more joined up approaches to unpacking and unpicking the challenges that they face through partnership with scientists. So this also identified areas of significance to multiple departments, as well as where the fragmentation of existing work exists. And if we look at the way in which funding is undertaken in this area, we know that the 2020 budget set out plans to increase public research and development investment to 22 billion per year by 2024 to 2025. If we, however, pause and look at the way in which research and development money is spent within the UK, we can see that there's quite a lot of variation across the different government departments. I think it's important to note that the current pattern of spend has not actually come from any systematic review, and it's not obviously related to the need or the scientific need, the societal need. The scale of relevant budgets reflects factors that have very little to do with scientific need. Most importantly, the fiscal pressures confronting the relevant departments in general and historical patterns of spend. So I think that a lot of the departments and the Government Office for Science has been leading on these conversations, need to really look at how the spending is spread out across government and where the evidence supports the spending across these different issues, and where we can join up work so that we're not recreating the wheel. So I think that I first really started engaging with different government departments as far back as 2009, and more of an advisory role. And that was after speaking with several departments with a nuclear power project when I was a postdoc, and moving forward. I remember conversations with the Cabinet Office long ago around resilience to flooding, community resilience, and we're still having those conversations right now. I also remember when the Government Office for Science published the UK Blackett Review for High Impact, Low Probability Risks. And they stated that for many high impact risks, we do not understand what the public actually expects in a situation, or how tolerant they may be of abnormal risks during a crisis. And this really changed the appetite for engaging with behavioral science. Quite often we have technical solutions, or we think about technical solutions to challenges such as building more dams or possibly not building houses on floodplains. But we don't often think about the behavior of publics or the behavior of staff within organizations. One of the examples, and I'm just keeping an eye on the time, so I'll move forward to this. One of the examples where I've seen a real difference in terms of bringing behavioral science into play in order to influence government processes and policy making is through the Behavioral Science Expert Group, which I chair for the Cabinet Office. This was the first expert group to be invited to engage with the National Risk Assessment and National Security Risk Assessment processes. They used to be separate, they have joined those processes. And we were established to provide independent evidence-based expert advice during the government assessment of the impacts arising from national emergencies. We were told that this was already an established process, that we could engage with it, but possibly not change it within the first year. However, we were given opportunities to change it moving forward. So as a result of our engagement, we generated 5 reports that made suggestions and led to changes in the NRA and SRA processes, especially the scales for measurement, the framing and representation of public responses to extreme events, and more. This research evidence also enabled civil servants to make the case for the first ever inclusion of guidance on what the public can do in response to risks identified in the 2017 National Risk Register. So instead of just saying that there was a risk or threat they needed to be aware of, it told them what they could do. We're also engaging with the Scottish Risk Assessment in a similar manner. So that's just an example of the UK National Risk Register, and you'll see up at the tip top on the left-hand slide, we have pandemic influenza as one of the most likelihood with the highest potential level of impact. If I think about what my work has actually brought to policy and practice, we have highlighted the importance of identifying and communicating effectively to address variations in public perceptions, practitioner and policymaker perceptions, assumptions, and responses. So understanding where people are starting from in their understanding of risks and threats, and also understanding the protective health behaviors that need to be undertaken or encouraged in order to decrease exposure to potential risks. We've also demonstrated that emergency policy plans and responses are often based on inaccurate assumptions about public responses. So they assume panic, when in reality, under response can be quite a challenge for us as well. And also they assume that members of the public have certain information needs. And we have seen communication in the past take place that didn't always address the concerns of the public. And so if that happens, they can look for information elsewhere. And we're all very aware of fake news, et cetera, et cetera. We've also demonstrated that the public are largely resilient to extreme events, and once again, challenged this misconception of the panic-prone public. In doing so, we've identified a range of responses during crisis, which can help organizations plan, as I said, all the way from under response to over response. And we've also demonstrated the importance of public communication and trust in informing protective health behaviors. These do come with their challenges, but in the interest of time, I can probably talk about more of these in the Q&A if anyone's interested. But I would say that the key challenge is always to be there as an independent voice, always to insist that if evidence exists, that the evidence is being used to inform the policies, the advice, the decisions that are being made. And if not, that we are aware of where we have evidence gaps and make real efforts to try to plug those gaps along the way. My final slide, so some more general thoughts about behavioral science and the engagement in the area of policy and practice, is that government approaches to security tend to focus on the physical science and technological solutions, but people are at the heart and the root of everything that we do. People design, use, and interact with the tools, security staff, publics, and potential adversaries. If we're thinking about health psychology, and I use theories from health psychology quite often, we're thinking about uptake of protective health behaviors. We're thinking about the way in which people respond to, let's say, air pollution alerts, or the length of time or their ability to follow through with a course of antibiotics. Behavioral science theories, methods, and evidence can improve the effectiveness of current approaches and also transform the effectiveness of future policy and practice. I've noticed a big move towards whole systems approaches to security. These are very much growing in popularity. And I would say, don't be afraid to go into areas where you might not have the expertise, let's say for sensor technologies, perhaps, because people are going to have to use those sensor technologies or have them used upon them. And so there's always something that behavioral science can bring if you can work with the experts in those more technical areas. And finally, I think it's very important to engage with the practitioners and policymakers, the problem owners, to really understand their challenges. And it's very, very easy to identify links with their area that they might not have considered or might not have been aware of in the past. Thank you very much.
Brooke, thank you so much. There are a lot of questions there, and hopefully we'll get a chance to come back to them in the Q&A. But now we're going to move straight away to Dr. Gemma Bauscher, who's a doctor by virtue of being a medical doctor, but is also a PhD candidate in the Department of War Studies, who's going to be talking about public health and governance challenges. Gemma.
Thank you very much for having me. Let me just share my screen first. So I'm delighted today to be invited to speak about COVID-19 in conflict, but also sort of more broadly the work that we do generally at the Conflict and Health Research Group. I think we've seen certainly during COVID, but also in sort of more ordinary times, that conflict creates environments with really highly constrained capacities to buffer the effects of spreading pandemics and other infection risks. COVID certainly is likely to be catastrophic for populations living in conflict zones, already living under the constraints of war. But from a scholarship perspective, attending to COVID-19 in conflict necessitates a reconceptualization of health threats within a highly specified security environment. The challenge for us, overlaying novel biological concerns onto an existing terrain of multimodal insecurity, really highlights vacuums in public health policy and practice. Also, I want to highlight that it also we've seen huge innovation and dynamism from context-led and locally driven programs, and that they've emerged within these vacuums, and that's interesting from an academic and practical perspective. Thinking back to Richard, who mentioned the Global Health Security Index, the index's 37 least prepared red states really highlight the importance of thinking about conflict specifically. So 18 of those states are subject to some kind of active conflict or insurgency. 5 of them are in immediate post-conflict phases, and 4 are subject to highly repressive military regimes. So already we can see that conflict emerges as an important associated condition of this inadequate pandemic preparedness or global health security, or whatever we call it as we move forward. We know that public health in conflict settings is already challenging, and that health systems in these settings are highly unique. Some reasons for that are reasonably obvious, but others less so. And they really are associated with critical features of contemporary conflict. So we know that the destruction of health services has become a feature of contemporary conflict in settings such as Syria, Yemen, where attacking health services, hospitals, directly targeting healthcare workers has come to really characterize the ongoing efforts and hostilities taking place. In just the last 6 months alone in Yemen, for example, more than 68 healthcare facilities have been destroyed. A bit over half of the pre-war facilities are still existent. If we look back simply last week in Afghanistan, you might recall in the press that there was a really brutal attack on a maternity hospital led by MSF. So this is forming an important backdrop to the insecurity in the health sector. Add on to that, we have a huge exodus of medical staff because of this pervasive insecurity, and public health issues provoked by large amounts of population displacement. For example, in northwestern Syria, more than 1 million people have been actively displaced since December alone, which again imposes huge novel public health challenges for local services. Because of that, what we see is various forms of weak or minimally coordinated health leadership in territories where there are opposing factions vying for territorial control. So even at the best of times, in ordinary times, managing healthcare for populations subject to violence is already a huge challenge. And what we see to fill that space is a patchwork quilt of disparate healthcare providers, whether they're from opposition groups, government forces, NGOs, military organisations, from international actors, multilateral organisations. And so we really have to take conflict health systems as a highly unique environment in which pandemic threats kind of arrive. What we also see is that alongside the complexity of the health system, we also have biological terrains that are hugely challenging in ways that we don't see in other settings. So, for example, we've had public health emergencies of international concern in 2 conflict settings in the last 10 years. That's 2 out of 6 public health emergencies occurring in conflict settings, polio and Ebola in DRC. So we have these settings that have to manage the dual public health emergencies, as well as coordinating really complex health work during conditions of violence. So the arrival of COVID has obviously further strained this difficult setting. I mean, testing is a valuable place to start to think about how this is operated. And what we've seen is a trend across conflict settings is that there have been delays in declaring cases, despite significant outbreaks in surrounding countries. Syria, for example, was very late to declare cases, even though it was clear that in neighbouring countries such as Iran, Jordan, Lebanon, for example, there were high case numbers about a month earlier from cases. Now, we can read into this 2 things. We know that there are political motivators for states not to declare outbreaks, although it does remain a duty of governments under the international health regulations to do so. But putting that aside, it's in a way, it's obvious that you can only declare cases if you're delivering some kind of testing or case finding program. And that's complicated to do. So in settings such as Syria and Yemen, where there are multiple parallel healthcare systems, testing mechanisms are highly regionally dependent. So, for example, the Idlib Health Directorate in Syria, which has been operating in an opposition region for 7 years as the technical health authority, only developed capacity for PCR testing a year ago to operate disease surveillance for coronavirus type infection, SARS type illness and influenza type illness. And that's been supported by the WHO and the Gates Foundation. But the degree of scaling up is really astonishing when you consider that only a year ago there was no testing capacity at all. So the target in that region today is 100 tests a day, but it's still reliant on reference laboratories in Turkey. So you can see already that issues around cross-border transfer of supplies start to come into play. Now, we've spoken about staffing and the exodus of health workers, but a huge amount of other kinds of staffing are required to deliver public health measures apart from doctors and nurses and in situ health workers. Again, the Idlib Health Directorate's shown good examples of community engagement in employing local groups already operating and well trusted in the local environments in conflict. So we've seen the White Helmets and the Syrian Civil Defence working together to implement mass voluntary campaigns called Volunteers Against Corona to capitalise on the role of social media and to raise awareness around public health messaging, identifying high-risk groups, providing assistance to contact tracing, that sort of work. And importantly, diaspora networks have been providing off-site, out-of-country clinical support. So that has already been up and operational during the conflict and is simply being repurposed and redirected. So there's a Syrian Public Health Network, that's a diaspora medical group, as well as the Syrian American Medical Service. But that's also, we have all of those issues with staffing, but we also have the ongoing challenge of ongoing conflict. It's easy to assume that COVID-19 turns up and hostilities are sidelined, but actually that's certainly not been the case. Although, for example, if we take Yemen, a ceasefire was signed partly to try to facilitate some delivery of health services. What was actually seen was a 30% increase in bombings during the time of the ceasefire. So as well as COVID-19, you have an escalation in the health demand with significant amounts of trauma coming into hospitals, as well as the ongoing geopolitics and logistics of managing really complex conflict. Afghanistan too, there's been negotiations between the Taliban and government groups to try to facilitate sort of so-called treatment bridges. Now, those have been variably effective. And I think what really emerges in these environments is that there's no one-size-fits-all approach for managing the delivery of healthcare in conflict. That it's really reliant on personal relations and local politics, and really expertise in local settings is going to be essential. I think if we think about equipment and we really focus on the role of critical care beds, we've seen that to be a cornerstone of disease response. Certainly in the UK, that's been a huge focus, is expanding the critical care bed space. Well, let's look at ventilators in conflict settings. There's an estimate of about 48 to 98 ventilators in the whole northwestern region of Syria. In South Sudan, in April, the International Rescue Committee estimated that there were 4 ventilators and only 24 ICU beds to support a population of 11.5 million. Now, we've seen in COVID that ventilators are an essential part of the clinical arsenal, but different pandemics will have different, very specific therapeutic requirements. Ventilators may not be the essential therapeutic agent in the next pandemic. So a lot of efforts going in now from UN OCHA and other organisations such as WHO to supply ventilators. But that's not good enough for the future and for future planning. And I've alluded to before the importance of these settings, maintaining their parallel health services, continuing trauma work. Yemen already has the world's greatest humanitarian catastrophe, ongoing malnutrition, new Ebola in DRC. These are rapidly evolving public health territories that really don't need the additional burden of COVID to strain already hard-working public health systems. So from a governance perspective, what can be done? Well, the WHO is obviously responsible for leading multilateral health efforts globally, and the cornerstone of global health security governance are the international health regulations, which is a legally binding instrument of international law. It mandates domestic and global disease responses. And the regulations really clarify the WHO's leadership responsibility. But that's not always straightforward in these environments of conflict, because lessons from previous outbreaks and previous public health emergencies show us, for example, during polio in 2014, that supporting on the ground efforts can be derailed very easily by environments of pervasive insecurity. So this was exactly the case during the public health emergency of international concern in Afghanistan around poliovirus, and the border activities were very important to this. So there were known reservoirs of poliovirus along the borders, but because of security concerns, civil mobilization programs, including vaccination, again, a cornerstone of that treatment, were banned because of concerns around terrorist activity. So the WHO there developed and leveraged its normative powers under the international health regulations to encourage multilateral coordination through a designated vehicle, the Global Polio Eradication Initiative, which required a lot of work on the ground with local communities, local opposition groups, to deliver vital public health services. And COVID-19 is likely to be a further opportunity for this sort of multilateral dynamism on the ground. There's a COVID-19 task force based in Turkey, supported by the WHO, the UN, and other international NGOs. And it remains to be seen how much this will come to characterize the health security response in these difficult security settings. So to finish, I really want to emphasize that in these settings, it's not simply a matter of dropping off medical supplies and leaving them be, and that's sufficient. In these really complex security environments, meeting the public health challenge requires prolonged public health work before, during, and after these health security events. And that work needs to be embedded in local communities and tailored to the very context-specific local security arrangements. Important also is the anticipation of secondary effects specific to these settings. So already we're seeing significant rises in food prices, crop outbreak associated crop failures, and reductions in remittances being sent with, as an important economic support to the country. If we look broadly at health governance during COVID, it's really, I think, highlighted the need for us to have sort of an on-the-shelf platform ready to go for coordinating the really important multilateral work that needs to happen. Surely COVID-19 is going to get worse in conflict settings, and it will also precipitate future public health and humanitarian challenges. And it will also alter the profile of ongoing insecurity and conflict in these settings. So really I want to finish with emphasising that the time to plan for that is now, and I'd be very happy to take questions later on this and any other aspect of the talk. Thank you very much.
Thanks very much, Gemma. We're now for the final talk. Everybody's been very good in keeping to time, so there will be opportunities for questions, so do send them in if you have them. But we now have Ivanka Bosashka, who's a research associate at King's and founder of the co-director of the King's Wargaming Network, who will talk about wargaming strategic decisions and outcomes in a pandemic and post-pandemic world. Ivanka.
Thank you very much. Thank you for the opportunity to talk about the work of the King's Wargaming Network over the past few months on examining the effects of the pandemic, as well as some of the ongoing research that we have with Professor Richard Sullivan and Professor and Dr. Matt Moran here at King's, and I'll walk you through the work that we have underway, and I hope you can see my screen now. So I'll talk about three things. The problem that that we've been aiming to address, the new tools that we're developing in applying wargaming to these problems, and some of the initial findings that that we're seeing, given that this is work that's still ongoing. So the pandemic has broad impacts across the social, economic, and political sectors, which will combine in new ways to produce second and third order effects. And this is the pandemic is occurring alongside existing challenges to international security, created by major power rivalry, terrorist networks, and so we're interested in understanding what these changes will mean to our societies and to the international system.
Hi, we seem to have a problem with Ivanka. I think her system has gone down, so let's hope we can get her back quite soon. But we've got plenty to talk about, fortunately, on the basis of the presentations we've heard already. So I want to start by posing a question, which is partly to Brooke, I guess, but I think is relevant to others. Because we've heard, I think you made two statements. Firstly, we want to be evidence-based, and secondly, that this is abnormal. And that raises an issue, is evidence comes from situations with particular underlying conditions. If the underlying conditions change substantially, what effect does that have on the evidence? Is it possible that you're drawing on evidence that just doesn't apply in the situations which you hope you're applying, that you're trying to apply? So and that relates to a more general discussion about evidence in this situation, which is partly, I think, raised by Gemma's presentation as well, which is, are we flying blind in terms of a lot of the world on this? And this is related also to one of the questions that I think has come in from people watching, which is, if you've got something like the Global Health Index, and it doesn't seem to have worked desperately well in this case in predicting what was going to happen, but how much are we working with some countries, including, say, the UK, where the evidence we've got now is pretty substantial in terms of what's been going on and the cases and so on, Germany and so on, and then a lot of countries where we really don't know, and have got a very and is this going to affect our ability to draw conclusions in the short term, given that the short term is still quite important because we're not through this, and many people are worried about coming peaks. So it's really a problem of are we flying blinder than we think we are in trying to cope with a situation like this? I'll put it to Brooke first, and then hopefully others can join in.
Okay, thank you, Laurie. I think, drawing initially on my experience from the counterterror research, we quite often see that there are active and live investigations that have to, of course, be undertaken within the law and with an eye on violation or trying not to violate any human rights. And they have to gather as much evidence as they can in a manner that then enables them to make decisions that will protect the public good or save lives, protect health. I think that we can see that in health response as well, as we have seen with infectious disease and especially with COVID-19. Very, very fast moving situation. I've lost the total in terms of the number of preprints that are coming out that everybody's trying to stay on top of. I would say that evidence should always be reviewed in every situation. When you're assessing any risk or hazard, you need to understand what you know, or what you think you know, and what you don't know. And sometimes you can't know everything, and a decision is still needed. I would say that I always draw upon well-established risk communication principles when communicating. If you're providing or asking, let's say, certain parts of the community or different communities to engage in certain actions, that you share the advice, you share the rationale, the reasoning for that advice, and you also acknowledge the impacts that this is going to have on daily life. You provide updates to let them know, is the change in behavior that you've been requesting, if we're asking people to be more alert in train stations, for example, is it effective? Is it having any impact on our ability or effectiveness? If you have new evidence, that means that you need to ask them to do something else. You then acknowledge what you asked them to do before, remind them of why you've done that, And then you provide the new evidence and say the advice is changing, this is the reason for it, and this is what we're going to ask you to do and what it will mean for your day-to-day life. So I think that evidence always needs to be reviewed. It's always changing. We do need to understand when decisions are made and the evidence that was available at the time that those decisions were made, but we must keep on top of it, reflect that, and also reflect that in terms of advice that is given for any kind of risk or hazard.
Thanks very much. We've hopefully got Ivanka back now, but just before, I just want to know if Gemma wanted to add a comment on that.
Yeah, I mean, I think so. Some very interesting ideas around the Global Health Security Index and this idea of failure have emerged. And I think that's what we've really seen, is that what we expected in terms of capabilities around global health security, which is a relatively novel sort of agenda in practice anyway, that what we've taken for granted hasn't really worked. And I think that what that's exposed is that our systems in countries such as the UK are not, they're not dynamic enough to outpace the rapid evolution of the biology, right? So we're reliant on the science, which is very important, but also we also have to accommodate the fact that we have a spreading pandemic in our country, and we have to decide what to do quickly. And we need mechanisms to synthesize that information. I think that's where globally and we've really seen that difficulty, and where we've seen disparate responses that are variably critiqued for sort of largely political reasons. And I think if you look at the Global Health Security Index, what that measures is the conformity of a state with the Joint External Evaluation Metrics, which is the mechanism that the WHO uses to measure a country's compliance with the international health regulations. So what is identifiable is that you can have a high Global Health Security Index metric, you can conform to the IHR, but that's not sufficient to protect a state against a pandemic threat. And that's probably not necessarily because of the health capacities of the states. It probably points to the fact that we need to look more broadly in terms of pandemics and epidemics than simply the health sector. Where issues have arisen is actually it's the interface of health services with the rest of normal life, with the economic sector, with the way that publics respond, and all of Brooke's very important behavioural work. And that's really, I think, an area that needs to be looked at now moving forward in terms of global health security and any way of measuring it to be valuable. I think we need to think how we integrate within those joint external evaluations mechanisms to synthesize evidence early and to address the quality of information before we can necessarily call it science, so that we can deploy measures before and in time to actually prevent the spread of these diseases. I know Richard would be able to speak more to that as well, so I'll just finish that there.
Okay, I think we're just going to carry on with the question and answer, but I hope Ivanka will join in. But Richard, this will be a segue into you there. I don't know if you wanted to pick that up.
I mean, maybe just add three things really here. Is I think we often underestimate the complexity of the sort of biosphere when we're dealing with pandemics. I think what this has illuminated is, first of all, that the importance of clinical intelligence, understanding the risk to people. And this is not simply locally, but in terms of clinical intelligence, you need to know what's happening to those populations who are already in the front line of any pandemic. And it speaks to the ability to rapidly synthesize and share timely, high quality clinical intelligence data, which we actually haven't got a system for. We rely on this rather slow and tedious approach, which is called scientific publications. And in something rapidly evolving and as kinetic as this pandemic, that's always going to get left behind, if you like. There's also then the risk, of course, to the healthcare systems themselves and the resilience that those systems have to any particular pandemic. And that forms another sort of ecosystem for intelligence. And finally, there's the underlying virology or bacteriology and its interface with the human immune system and any potential movement either from humans back into animals or animals back into humans. So you can see here just three very distinct areas of knowledge, very distinct areas of processes and intelligence gathering that have to come together and work very seamlessly to provide decision makers with really timely biointelligence. And I think it's fair to say that, you know, we've my personal view is we've rather neglected what I call the field work here, actually getting out on the ground and working in the real world in favor of models. And, you know, we understand why we have models, and they're very useful, but they are just one aspect, if you like, of the armamentarium of making high quality sort of biological intelligence for policymakers. And I think that's something that's going to be scrutinized very heavily now when we have a chance to breathe. So I'll stop my comments there. Thank you, Lawrence.
Thanks, Richard. I mean, just following on with that point, and I'm trying to draw in things, the questions that have come in as well, but it also comes back to what Philippa was talking about with the Chinese narrative of the moment. I mean, one of the things that we've seen, you could argue, is a pandemic of research. I mean, there's masses and masses of stuff coming through, and it's not peer reviewed. I mean, it's all pre-peer review stuff going up. All the imperial research is all pre-peer reviewed. Now it's slowly being peer reviewed. And we've had one example of this paper that was slipped into New England Journal and Lancet and so on, that turns out to be basically fraudulent. So there's, and it partly relates again to the problem of evidence. One, the risks of the scientific evidence being manipulated, not just the stuff that Brooke was talking about in terms of panic and so on, and what we think about public attitudes, but the actual risk that what we think we know about this disease is being politically manipulated, or just manipulated with by sort of eccentric, let's see what we can do for fun types. Perhaps Richard, and then maybe Philippa would like to come in on that.
I'm afraid, I'm afraid from my perspective, I'm sure Jen will agree, we have to agree with you. I think, you know, in the effort to get out information, we bypass some of the normative mechanisms for peer review. In some cases, I think some papers have come out in preprint that have been justified because that data's had to come out very quickly. In many cases, I think when we wash this up, we will see data that has caused extraordinary damage. And I'm not going to pick particular examples. There are papers coming out on the risk to surgical patients of COVID-19, causing an almost instantaneous stoppage in routine surgical services, for example. And this is something we've had to contend with. But what's happened, of course, is that the system has filled a vacuum here. Nature abhors a vacuum. People have been desperate for information to guide their everyday clinical practice, hospital levels, etc. So if you said you've had this infodemic from the clinical, the scientific communities, as people have piled into this vacuum. And I think we've not really had, any decision-making body in any country has probably really struggled to distill and metasynthesize all of this and exploit it in a manner that they can do reasonable assessments with. And I think we just have to find a different way. But I think your assessment is right. But I'll hand over to others for comment.
Philippa, if you want to come in.
Yes, I would. Thank you, Laurie, because I do think that this problem of evidence also very much relates to any kind of origin investigation. Clearly, for an origin investigation, we need to look at the sorts of evidence like case histories. We need to look at the epidemiological data. We need viral samples from different times and places, including the earliest possible samples from infected individuals and samples from wildlife. So the science bit is absolutely paramount to this kind of investigation. But if we're going to have a real credible forensic investigation, we need to look at other kinds of evidence too. And here I'm talking about auditing and sampling viral collections in the Institute, for instance, that have been studying coronaviruses. We need to examine the sorts of experiments that were carried out, the viruses that were used. We need to review safety and security practices. A lot of this data would be coming from from documents, so the sorts of standard operating procedures that are in place, both in the labs and for field work, the sorts of risk assessments that were carried out for experiments. We need to look at accident and infection records. So there's a whole host of documentary data that needs to be looked at. And in addition, we would have to do interviews with facility personnel, the researchers themselves, observation of lab facilities, as well as fieldwork sites. So I think this idea of evidence and what counts as evidence is important, not just in our public health response, but also very much in finding out where that spillover event happened. And at the moment, that's very controversial, obviously, but I think if we're going to do this in a credible way, that's the sort of investigation it would take. Thanks.
Thanks very much. Maybe Brooke would like to comment on that, but I'd also like to put to her a question that's been put, I think, from Jim Wilson, which is about the sort of the concept of resilience and how it relates to vulnerability. I mean, you've worked with concepts of resilience for some time, but are they good enough? It can mean very many different things to different people. Whose resilience in the end are we talking about? But so there's a question, but you may want to comment on the evidence point as well.
Okay, I'll start with the evidence point as best as I can. I'll say that we have challenges, of course, especially if you think about the immense pressure to publish and not to publish always questions or challenges that you've found, but to publish beautiful, complete work in which we all say we have loads of confidence. So I think that scientific discourses in real time should be about saying, I have this interesting evidence, it's clarified some things, but it's raised more questions, and to put that out there. But because of the pressures of publication, we're always trying to have these beautiful, pure publications polished and put through the peer review process. So I think that we need to change that model and talk about certainty, uncertainty more often in our publications. I'll also say that we have public health impacts gone wrong through slow time publications, such as the Andrew Wakefield publications around the MMR vaccines. And that was not a crisis. We were not managing a crisis at that point in time. So, you know, this can get through even at the best of times. I do think that as all of this information is coming out, that it is very, very much down to the scientists to discuss the strengths and weaknesses of the publications coming through, and that we should discuss that, and that we should issue challenges, or if something's really interesting, try and share it across our networks. And so, you know, I'm really keen on the evidence. I think that we have some cultural challenges in the way in which evidence is sought after in slow time, and those become even more pressing when we're all trying to figure out what's going on and publish that right now during C19. If we start thinking about the concept of resilience, and I've got so many windows open, I'm new to the Zoom use of this. I do Zoom for the smaller meetings usually. So I think that we need to think about resilience of organizations, resilience of systems that connect these organizations, and also connect the organizations to communities. As well as community and individual resilience. And so there are so many levels at which resilience operates. And one of the main concerns that I would have in thinking about the final outcomes of organizations, of systems, of communities and individuals as they move through this COVID-19 curve that we're seeing is, what was their state of resilience before it struck? So did they come to this event with higher or lower levels of resilience? And if so, what were the contributing factors in forming those higher or lower levels of resilience? Is it investment in infrastructure? Is it good or high levels of public health, or poorer levels of public health? You know, what were the systems? What were the systems like before we got to that? And then we can see the real impacts as they work through that curve with us. And so knowing what resilience looks like, knowing the health of our systems, the health of our communities, the health of our organizations before an event takes place. And we should be having these conversations all of the time. Resilience is a really tricky one to get organizations interested in and to get funding for. It's a very difficult thing to pin down what it actually means. And I think that COVID-19 is almost a perfect case study to say, where were we before it and how did that play out during it? And can we intervene during this curve in order to enhance resilience of communities, of organizations, when we see that they're a bit lower than they should be? What can we do in real time instead of just waiting and saying, well, your resilience wasn't really that high when we started, so it's logical that you had lesser outcomes than other people. Can we intervene in real time, and how can that intervention work across diverse communities and organizations?
Thanks. Can I bring in Gemma because on this partly, well, just responding to one of the questions that's been posed, but it flows, I think, from what Brooke just said. One of the things we're worried about in our countries is the potential interaction of COVID with normal seasonal influenza later in the year. Now, you've got to try and imagine some of the countries you were talking about with, again, another Ebola epidemic, as we've seen some worrying indicators. I mean, is there a risk of sort of perfect storm in some of these countries whereby not only do you have the conflict and all the consequences of that, but you've got COVID-19 lurking around to a degree we don't know, and then something else occurs as well, because your systems have been undermined so much by what's gone before. I mean, if you any views on that?
I mean, and certainly I think that's absolutely the case. The kinds of challenges that countries such as, I think Yemen is a very good example, are having to meet they're totally alien to what we, our concerns about the dual influenza and coronavirus, which is certainly significant. As a clinician, certainly I worry about when that happens. But I suppose with Yemen, your question is really, how much worse is it going to get, and how much worse can it get? Because you already have the world's greatest humanitarian catastrophe. You already have vast swathes of pediatric malnutrition. You already have issues with cholera, ongoing conflict with bombings, and yes, COVID comes in. One issue is that it may be difficult to know how bad it gets because of other public health issues, right? So difficulties testing. Already we know that in the city of Aden, there are about 80 excess deaths a day compared to what there were prior to the pandemic. Now, without doing an all-cause analysis of that, we don't know exactly how COVID interfaces with it, whether they're direct deaths or associated deaths or whatever, but we certainly know that this brewing public health catastrophe, that we're really only at the beginning of it, right? And that COVID is almost certain to precipitate a variety of both proximate and distal effects. So one of the things I'm particularly concerned about, my PhD research, is about antimicrobial resistance, so antibiotic resistance throughout conflict settings. Now, one of the mainstays of treatment for COVID-19 is to treat the superadded bacterial pneumonia. So what do you use? You use usually multi-agent antimicrobials. Now, in settings with already high levels of drug-resistant bugs, you're brewing a further catastrophe by taking out of play an essential medical therapy for now and in the future. So certainly I think planning needs to be very specific to these environments to address local patterns of virology, bacteriology, and really specific conflict-associated features. Certainly, my prediction would be that in settings such as the UK, we'll see issues in similar ways, and that we'll have to do all-cause analysis when all this is done to see how we can address and identify different causes of death. But if we don't attend to those very, very important risks now in conflict settings such as Yemen, the catastrophe that we already see is going to be a lot worse for a long time to come.
Thank you. Richard, do you want to come in on that?
So I absolutely totally agree with Gemma, and I think what we have to be able to do is dissect out the differences between the direct impact of COVID-19 in these humanitarian fragile settings. And the important thing with the direct impact is that we've made assumptions about what the risk factors are: greater than 70 years old, certain significant comorbidities. And then from the data that's been coming in, other things like HIV/AIDS are not a risk factor. But those are prejudices because that is the data we're working on. So when someone reports from a fragile country that they are seeing an increase in all-cause mortality, as Gemma said, you have to look for the unusual. So you do have to ask the question whether for some reason, some risk factor this population has is making them more vulnerable to the virus itself. But the counter side to that is to say that the mere fact of talking about a pandemic like COVID-19 instigates changes in behavior. Brooke knows very well, and the patterns of care seeking and care delivery. So people start changing their behavior patterns in care seeking. They become worried, even if they shouldn't be, about going to the local hospital. And then you find a woman, for instance, in breech labor dies at home because she won't go to the hospital because she thinks she's at risk of getting COVID-19. And secondly, humanitarian organizations then, or other care providers, start stopping their services or changing their services. So the excess mortality and morbidity may be nothing more than an indirect impact of the fear of the pandemic. But the difficulty with all this is, as Gemma said, you need to get on the ground there. You can hypothesize about this, but this is the sort of areas where we actually have to get into these settings and really understand, both from a clinical perspective and from a behavioral perspective. And they're very complex ecosystems to work in, but they're essential because this a majority of the population around the world is living in fragile and conflict areas. And we have very little insight at the moment into what's going on with this pandemic in those places.
Thanks. There's a question that's been put about surveillance, which I may come back to you about, Richard. But first, there was also a question to Philippa, which was asking about whether we think there's the question was whether it's a natural or deliberate outbreak, COVID-19. And I think you indicated it probably wasn't deliberate, but it does raise questions about what happens in the future if something deliberate is planned, because I think from what you were saying, you could see how this could be weaponized if it came from if it came accidentally from a lab, then it could also come potentially deliberately from a lab. Anyway, that's a scary question to put to you.
Thank you, and thank you, Rubina, for the question. I thought I had made clear that certainly my sense is that this is a natural outbreak. That's what all our evidence points to. But what has been very interesting around this origin discussion is that there are many people who have conflated the idea of the origin being possibly coming from a lab with it being deliberate. So what that has caused is a lot of people who should know better saying it's not possible that it could have come from a laboratory, because they want to distance themselves from misinformation and disinformation, and merely referring to it as conspiracy theories. And it isn't. It's a very likely possibility that, it could have. It is a possibility that it could have come from a lab. The prevailing theory is it's probably not from a lab, it's probably from a wet market or somewhere else, but it still could have come from a lab. One of the slides that I put up showed some of the efforts that there were at debunking the disinformation campaigns around the connection between the pandemic and bioweapons theories. So there were some very prominent news outlets like Washington Post, Foreign Policy, who came out and said, clearly debunking connections between the pandemic and a deliberate outbreak. Also articles by various experts. There is no genetic evidence for this. There is absolutely no motive for this. And so I think that's very clear. You also, in your question, asked about biosecurity policy and where does this go?
As it's also what this may not have been deliberate, but in the future, could it be?
Certainly, it could be in the future. And I think we're at a point where we're seeing a buildup in capacities around the world for in dual use capacities around the world. So we're seeing more and more high containment facilities being built. We're seeing more and more people working with dangerous pathogens. We're seeing science being advancing so quickly. There are things we can do now we couldn't do last year or even last month. You know, it's a very fast moving field. And if you take all of that alongside the entire security context, there are real concerns about the potential future biological weapons. So certainly that is an issue. And if we are going to talk about how do we counter that, we need to have a comprehensive response. And that really speaks, Rubina, to your point about, well, what do we do in terms of the biosecurity policies? Clearly, they need to be both top down and bottom up. So we need to sort out our international multilateral treaties around this. The Biological Weapons Convention needs to be strengthened. The Geneva Protocol needs to be strengthened. We also need to make sure these international law is implemented nationally in national law, globally. And we also need a lot more bottom-up efforts. We need to raise awareness of these sorts of dual-use risks among scientists, develop codes of conduct and codes of practice, and all those sorts of things. What has been an issue is that biosecurity hasn't been seen as particularly relevant, as particularly significant. And I think one of the impacts, more positive impacts of COVID perhaps, is that this will now bring more attention on the need to focus on implementing biosecurity policies.
Thanks. We're almost out of time. If somebody would like to come in very quickly on the question of surveillance, because this has been raised by one of our viewers on the basis that there seem to be different cultural norms and expectations in different parts of the world on this. Are we likely to converge as a result of seeing the need for more surveillance in order to trace how the virus is developing, or maybe perhaps there'll be a reaction? Somebody like to come in just quickly on that, just to finish us off. Brooke, you're
I suspect that
quick on the draw then.
Yeah, well, I suspect that I can, because my colleague Julia Pierce and I have quite often looked at cross-cultural differences for lower likelihood, high impact events such as CBRN terrorist events. And in doing so, we've looked at the different perceived risks, understandings, information needs, levels of trust, and more between populations and their governments or the organizations who would be communicating with them. So we certainly do see that there are very, very often clear psychological principles that are driving the way in which individuals want to receive information and engage with the sharing of information. But we also see that there are some very, very clear cross-cultural differences. I'm a bit Western-centric with my research, so we've even seen across Europe that because of the past, for example, how governments dealt with, the ways in which governments dealt with radiation incidents in the past, that their members of the public aren't as trusting of the information coming out right now in the future, and that impacts their behavior. If we look at surveillance, I do think that you have to be very, very aware of the relationship of trust and the historic relationship of trust between publics and their governments, or if there are industries involved, that relationship counts as well. And I think that no matter what, especially in the Western world, we have to be very, very clear about how the data is being used, how long it's going to be held, where it's going to be stored, et cetera, et cetera. If this is something that we're going to be facing again and again into the future, is this a system that needs to be stood up repeatedly in order to start mapping and tracking symptoms? We have quite a few things that can do that already. So I also think that there have to be clear agreements and systems built in to say that there is an end game to each surveillance mechanism that's stood up. We have to have clear rationale for standing them down and an ability to stand them up again quite quickly if needed.
And on that, I think we have exactly reached 4 o'clock, which is the scheduled time to close, and it's always a good idea to stick to scheduled times. So on behalf of everybody who has been tuning in, I want to thank our panelists for fascinating discussion, important issues raised, lots of questions with which we're left. But thanks to them, thanks to the School of Security Studies for organising all of this, and we hope you'll carry on with this series. Thanks very much indeed. You can, I think there are ways of clapping on Zoom, but and if they are, please do so. Thanks very much.
Thank you, Laurie.
Thanks very much.